Hello, my name is Dr. Jeffrey Barsuk. I am a professor of medicine and medical education at Northwestern University Feinberg School of Medicine. I currently serve as the Director of Simulation and Patient Safety. I'd like to welcome you back to yet another podcast in our series on simulation and healthcare education. Today, we plan to highlight Chapter 6 on standard setting for mastery learning in our book called Comprehensive Healthcare Simulation, Mastery Learning and Health Professions Education. Today, I have the distinct honor of interviewing Elaine Cohen, who is filling in for her co-author, Dr. Diane Wayne. Elaine, or as we say, Lainey, is a research associate at Feinberg School of Medicine and has a Master's of Education in Measurement, Evaluation, Statistics, and Assessment. Lainey, it's an honor to interview you today.
It's a pleasure to be here. Thanks for having me.
So all the podcasts usually start off with us learning a little bit about your background and how you got involved in research.
Yeah, so I graduated from the University of Wisconsin with a degree in sociology and statistics. And while I was in college, I had a student research job entering data for a pediatric asthma research project. The families got an educational intervention and they learned about how to manage pediatric asthma. And it was a randomized trial. I really liked doing it. So ever since then, I knew I wanted to be involved with research. So after I graduated, I was looking for jobs in Chicago and I got a position in the Department of Medicine working with Diane Wayne in the residency program. Simulation-based mastery learning was just starting to take off in the residency program. And I started to work with you, Jeff, and Bill McGahee, and just learning more about the process. I earned my master's degree during that time, like you mentioned. And I've come a long way since then. I continue to support all types of simulation-based mastery learning projects. And now not just for residents, we're studying nurses, attendings, and even patients and caregivers. So it's really exciting.
So Lainey, you have been key to our research program, and one of your responsibilities has been helping to develop minimum passing standards for all of our simulation-based mastery learning curriculum. And I know there are several methods we have used for standard setting in the past to set that minimum passing score. Can you take us through some of that history?
Sure. Yeah. So like you said, there's several methods for setting a minimum passing standard, or sometimes I might say MPS. I will use them interchangeably in simulation-based mastery learning. And the standard has to be achieved on a final assessment by everyone before the end of training. So historically at Northwestern, we use two widely accepted approaches that have been studied in the medical education literature, and those are the Angoff method and the Hofstee method. So after you develop and pilot a curriculum and assessment tool to sort of turn it into a mastery learning curriculum, you have to set standards on the assessment tool, and usually that's a skills checklist. So during a standard setting session, we invite experts in the skill to come and make judgments on how learners should perform in order to pass that assessment. So the Angoff method, which I mentioned, it's an item-based approach, meaning it considers each item on the examination or the checklist. And the experts are asked what percentage of borderline learners would get each item correct at the end of training. And the borderline learner is someone who we think has a 50-50 chance of getting that item correct. The Hofstee method, the other method I mentioned, looks at the checklist as a whole and asks for 4 questions about the test, and those are used to plot a standard on a graph. And if listeners are more interested in those details on the Angoff and Hofstee method, those are in the book chapter on standard setting. But because the Angoff method resulted in more lenient MPSs, and the Hofstee tended to produce more stringent ones. We took an average of the two historically to set that final minimum passing standard. And this worked really well for us for many years. We used these methods to set standards for several SBML or simulation-based mastery learning curricula. And we published a lot of papers using these methods.
Yeah, so one key thing to consider is that for these methods, as of course you know, but for our listeners, we are asking the judges to make their assessments of what the performer would do after they've already completed training. So tell us a little bit about why you and we stopped using the Angoff and Hofstee methods.
Yeah, so the main reason we're not using Angoff and Hofstee anymore is if you actually think about them, they're not well suited for mastery learning. They were created for normative assessments or tests with normal learning curves. And mastery learning, it doesn't produce a normal curve distribution. We get a J curve or a J distribution because everyone keeps practicing until they actually meet the minimum passing standard and ace that final test. So it's more left skewed. And our mentor, Bill McGay, he calls this excellence for all. Also, in the Angoff method, judges consider a borderline trainee, so someone who has that 50-50 chance of getting a checklist item correct. But in mastery learning, we need to get to the right side of that curve and get learners to that high level of skills for patient safety. So I know I wouldn't want a borderline trainee taking care of someone in my family in the hospital. So another consideration is that in mastery learning, even the borderline learner will reach that minimum passing standard and achieve excellence. Because time isn't an issue for mastery learning. They just keep practicing until they get it. The last reason why we stopped using the Angoff and Hofstee is it's a little confusing for judges to conceptualize that borderline trainee. And what a judge considers borderline could vary from institution to institution and the experience of the judge. Most judges, though, can agree upon that concept of a well-prepared trainee. For the Hofstee method, 2 of the 4 questions that we ask judges are what's the minimum and maximum acceptable failure rates for assessment? And the problem is in mastery learning, there are no failures. All trainees get to that mastery level. So that didn't make sense to us either. So to address these issues with the Angoff and Hofstee, our friend at UIC, Rachel Yudkowsky, developed a modified Angoff or a mastery Angoff method and a patient safety method for setting those minimum passing standards.
So for our listeners, UIC is University of Illinois at Chicago. So we got now the modified or mastery Angoff and the patient safety method for setting the minimum passing standards. What's better about these approaches? You know, how do they work? Why do we use them now?
Sure. So first, let's talk about the mastery Angoff. This is the method we use currently, and it's our preferred standard setting method for any mastery learning curriculum. The mastery Angoff method asks judges to think about this well-prepared trainee as opposed to a borderline trainee. And that makes more sense for mastery learning. And like I said, it's easier for the judges to understand. We ask the judges to consider how a well-prepared trainee will perform each task on that checklist after training. So the well-prepared trainee is one that can perform the skill independently and safely for patient care. There's another standard setting method also developed by Rachel Yudkowsky called the patient safety method. And that method, the judges are asked 3 questions about each checklist item. Whether or not the item has implications for patient safety, comfort, or clinical outcomes. And if they answer yes to any of those questions, it's considered a critical item. And if it doesn't meet any of those criteria, it's non-critical. Then the judges set two separate passing standards, one for the critical items and one for the non-critical items. We don't tend to use this method in our work, mainly for two reasons. Number one, it's definitely a little more complicated than the Mastery Angoff and takes a little more time. And two, when we develop checklists, we tend not to include those non-critical items.
So, Lainey, our group has done some work to study and evaluate the differences between the more traditional Angoff and Hofstee like we used to use and the new Mastery Angoff and patient safety methods. So can you take our listeners through those studies, that work that we did?
Sure. So we took the skills checklist from our central venous catheter insertion curriculum, and we have been using that curriculum for a long time. We've taken lots of learners through it, and we had already set standards using the traditional Angoff and Hofstee methods for that curriculum. We found the Mastery Angoff led to more stringent passing standards than the traditional Angoff and Hofstee average. So using the traditional Angoff and Hofstee, the minimum passing standard allowed learners to miss up to 3 items. And using the new Mastery Angoff method, trainees could only miss 1 item. Interestingly, when we used the patient safety method, we found the exact same standard as the Mastery Angoff method, that they could only miss that 1 item. So we think this is because we had no non-critical items on the checklist, like we discussed. Something to keep in mind, though, we did link our traditional minimum passing standard using Angoff and Hofstee to improve patient outcomes after central line insertion training. And we really don't know if using the standard from the Mastery Angoff would produce better patient outcomes.
I think it's going to be hard to do that study, really, because you're talking about missing 3 items versus 1 item. And is that really going to result in, we showed lower central line associated bloodstream infections as a result. And is that really going to show anything clinically meaningful?
Yeah, it'd be hard to measure.
Rachel Yudkowsky and I often discuss this and debate whether it can be measured, and I don't think it can. Also, one thing to mention is that it seems that the Mastery Angoff is more robust because it's not influenced by test data. We actually did a study where we compared ratings on the traditional Angoff and Hofstee, where we shared actual pilot testing data with the judges, and it influenced the results of the Angoff and Hofstee scores. It made it more stringent in this case if the judges saw the test data. However, when we showed the judges the test data for the Mastery Angoff, it didn't influence how they gave the scores, which I think is more related to understanding what a well-prepared trainee really looks like as opposed to a borderline. All right, so now the listeners understand the concepts behind setting a minimum passing standard, but let's go through a little bit how it actually gets accomplished, the nit and gritty. Can you take us through how one of these standard setting exercises work?
Yeah. So let's say you developed a new curriculum, you created a checklist for the skills assessment, and you're ready to turn it into a mastery learning curriculum. The first thing you need to do is to get that expert panel of judges together. So we recommend about 10 to 12, 8 at the very least. And you want a diverse group of experts. So different backgrounds, program directors, educators, clinicians, depending on the subject matter. They just need to be familiar with and actively performing or supervising the skill that's being assessed. We try to ask the judges to come for 2 sessions, at least 6 weeks apart. That way they do the exercise twice and they can show stability of their responses. And we usually do the sessions at lunchtime. We order sandwiches or something because everyone has a break at lunch and usually has some free time then. Before the meeting starts, we create this standard setting packet, and there's an example of that in the book. It gives instructions for the exercise, copies of the checklist,